Hi, I'm Jennifer Jager. I'm a PALS instructor from the RIC Simulation Center in Terre Haute, and I'm going to be talking to you about care of pediatric respiratory emergencies. Priorities in managing the seriously ill or injured child is evaluation of their airway and breathing. You want to be alert for signs of respiratory distress and/or respiratory failure. Respiratory conditions are the main cause of cardiac arrest in infants and children, and intervening quickly restores respiratory function. Clinical signs that you're going to want to assess for is increased respiratory effort. In children, you're going to look at nasal flaring. You're going to look for intercostal, subcostal, suprasternal retractions. You want to look for inadequate respiratory effort, hypoventilation, or breathing that's not fast enough to maintain their oxygenation. You want to listen for abnormal airway sounds, for example, stridor, wheezing, or grunting. You want to observe for tachypnea. You want to assess the heart rate. You want to assess for pale, cool skin or any changes in level of consciousness. Respiratory failure. These are some of the signs. Marked tachypnea, they're breathing quite rapidly, but eventually that's going to slow down to become bradypnea or apnea when they wear out. Increase respiratory effort, then it'll become decreased, and then you'll have no respiratory effort. Poor to absent distal air movement, so when you listen to the lungs, you won't hear as much movement of air all the way to the bases. At first, the heart rate's going to be fast to compensate, but then as the child's body wears down, you're going to have bradycardia. You're going to observe for cyanosis, and then a late sign would be a stupor or coma where the brain's not getting enough oxygen. Some initial interventions for all respiratory problems would be support and open airway. You want to allow the child to assume a position of comfort. That may be sitting upright on the cart. That may be laying over mom's shoulder. Whatever way they're comfortable, try to allow them to maintain that position. Clear the airway. This is important in pediatrics. The younger the child, the more they rely on breathing through their nose. So you want to make sure you suction their nose if there is a lot of mucus, an occlusion. Dried secretions can completely occlude their nasal passages. So you want to clean that out. Maybe in small infants, they have mucus in their mouth that they can't clear. So you'd want to suck that out. You want to consider an artificial airway to improve any airway patency. Some initial interventions for all respiratory problems would be monitor their breathing. So you want to monitor their O2 sat by pulse oximetry. If they're a small enough infant, you can put it around the edge of their foot. You might put it on their big toe, maybe on a thumb, wherever they'll leave it. Provide O2. You can initially start with a 100% non-rebreather, which is always the right answer in PALS, but any method of airway delivery that they're comfortable with might be appropriate. Just remember, if their nose is clogged with secretions, you wouldn't want to use nasal cannula. You would want to use something that covers their mouth also. Some kids aren't comfortable with the mask entirely covering their face, so they do prefer nasal cannula if their nasal passages are clear. Administer inhaled medications is needed, assist ventilation with a bag mask device or oxygen is needed, and be prepared to intubate if necessary. You also want to assess circulation. So you're going to monitor the heart rate, the heart rhythm, and a blood pressure, and then establish a vascular access as indicated. You want to identify what type of respiratory problem you're dealing with so that you can figure out your next interventions. There are 4 classes of respiratory problems: an upper airway obstruction, a lower airway obstruction, lung tissue disease, or disordered control of breathing. So obstructions of your upper airways would be those of the nose, pharynx, or larynx. So common causes are foreign body, whether it's an actual toy, it could be food, it could be something the child put in there, it could be swelling and mucus. Anaphylaxis, tonsillar hypertrophy. Frequently children, they have large tonsils, and if they're infected, they'll be even larger. Croup, epiglottitis. Epiglottitis is common in children who aren't vaccinated, so have that in the back of your mind if you know you have a family who doesn't administer vaccines. A peritonsillar abscess, a pharyngeal abscess, thick secretions, or a congenital abnormality may make their airway partially obstructed. Signs and symptoms of upper airway obstruction. Usually you're hearing these sounds on inspiration. You're going to have tachypnea, they're breathing rapidly, increased inspiratory effort. So they usually will have their suprasternal retractions and nasal flaring. They may have some hoarseness. They're going to have the barky cough. They're going to have stridor, where you hear the sound on inspiration. Poor chest rise. There's going to be poor air entry. They can have cyanosis. Frequently, these kids are drooling because they can't swallow their secretions from all the swelling. They will have that cough that's usually barky. You'll see some seesaw breathing where the abdomen and the chest look like a seesaw from each other. And the respiratory rate is going to be mildly elevated. They're having to produce some work to get the air in. Management for upper airway obstruction. Again, let the child assume their position of comfort. This is a child you want to avoid causing them to cry. So generally on mom's lap, on dad's lap, however they want to sit. Remove the foreign body if possible. So if you can suck the bean out of their nose, if whatever's in their airway can be coughed up using Heimlich or whatever that might be. You want to suction the nose and or mouth, and again, consider their agitation level. If they are done having their nose sucked out and they're relatively stable, don't make them cry. Reduce the airway swelling with meds, so you'd want to consider steroids, Decadron, possibly a racemic epinephrine treatment. You want to minimize agitation. Again, get in, get out. They're probably going to be scared of people in scrubs, so be in the room as little as possible. Decide if an airway adjunct or advanced airway is needed. Maybe they're going to need intubated because you just can't maintain a safe airway. And decide early if a surgical airway is needed. So do you need someone on hand who's capable of performing a tracheotomy? Specifically, management of croup, something that you're going to see frequently. Consider dexamethasone. Humidified oxygen, the humidity in the oxygen is going to help the disease process. You do not want to feed them, so no more things to eat or drink, especially fatty milks, things that are going to make them cough, produce more secretions. You want to consider nebulized epinephrine. If respiratory failure is impending, high oxygen, so you want to try the non-rebreather. Assist ventilations if necessary. Again, administer dexamethasone for sure, and you're going to intubate with an ET tube that's half size smaller than indicated for the child's age or weight. If your upper airway obstruction is caused by anaphylaxis, you administer IM epi every 10 to 15 minutes as needed, and know that multiple doses may be needed. You want to treat bronchospasms with albuterol. You can give a continuous albuterol treatment if indicated. For severe respiratory distress, anticipate that the airway is going to get more swollen and prepare for intubation. You can administer diphenhydramine and an H2 blocker IV, and you can administer methylprednisolone IV to help control the swelling and inflammation. Lower airway obstruction, this is what's occurring in the lower trachea, the bronchi or bronchioles, and the most common causes of lower airway obstruction in children is asthma and bronchiolitis. So those lower airway signs and symptoms are going to occur during expiration, where your body's trying to get the air out and is having some trapping. You're going to have tachypnea. There's going to be wheezing. It's usually on expiratory, but could be on both or just inspiration. Increased respiratory effort, retractions, nasal flaring, and the expiratory time is greater than the inspiratory time. And then an important thing to look at is the expiration is an active rather than a passive process. So they're really working to get that air out. And then also a cough. Management of bronchiolitis, and that's RSV, follows under that category. You want to perform oral and/or nasal suctioning as needed, and kids with RSV generally have lots of nasal secretions. You want to consider labs, viral studies, and a chest x-ray. You can consider trialing epinephrine or albuterol, but studies show it's not always effective. And administer oxygen to keep your SATs greater than 94, and then of course, per PALS guidelines, if your SATs are greater than 99, you would wean. Lower airway management for asthma specifically is humidified oxygen via nasal cannula or mask to keep the SATs greater than 94. Administer albuterol, you could consider a continuous treatment. Administer corticosteroids. Administer Atrovent, a little longer acting. Consider establishing vascular access for administration of your fluids and meds. Perhaps they're breathing too hard to drink and they can get dehydrated from the tachypnea. And also you may need an ABG and chest x-ray. So if you have a child with asthma and you have impending respiratory failure, you want to make sure you're giving high concentration of oxygen. The continuous albuterol treatment, definitely IV corticosteroids. You can consider terbutaline. BiPAP will help if you have the mask that would fit. And then consider intubation if the oximetry is low and the conditioning is worsening. They're not able to stay awake and talk to you and answer your questions anymore. They have irregular breathing. Be prepared. So lung tissue disease. That is a group of clinical conditions that are going to affect the lung at the level where gas exchange occurs. So the alveolar and small airways collapse, or the alveoli become fluid filled. And examples of this are pneumonia, pulmonary edema, a pulmonary contusion, possibly following an accident or trauma, an allergic reaction, or toxins that may have been inhaled into the lung. You can see any of those with children in the pediatric population. Signs and symptoms, tachypnea. They are breathing fast. Increased respiratory effort, so using all their accessory muscles. Grunting, and then remember too, frequently if children are grunting, that respiratory rate's going to come down, but if they're done grunting, then they're tachypnic, so it may go back and forth between a fast rate and a normal rate. You're going to hear crackles when you listen to their breath sounds, which are probably going to be diminished. The heart rate's going to be increased, trying to compensate for all this, and you're going to have hypoxemia. So management of infectious pneumonia, of course, first are your ABCs. You want to consider CPAP, non-invasive ventilation, or mechanical ventilation. Diagnostic tests, your CBC, chest x-ray, anything, maybe swabs to rule out some things and decide your treatment from there. Antibiotic therapy, you want to start that early after cultures are drawn. You want to treat any wheezing with albuterol. If they don't have wheezing, that may not be necessary. And then reduce metabolic demands by normalizing temperature. That's important in children. They should be the temperature should be normalized with Tylenol, but also if they are cold, you want to warm them up. The management of pneumonia, pneumonitis, I should say, inflammation of the lung tissue caused by inhalation or aspiration, and kids try to drink the craziest things. Infants, maybe someone's used baby powder and they've inhaled that. You never know what kids get into, but toxic liquids, gases, dust, or fumes into the lungs. Of course, first ABCs, you want to treat wheezing with a bronchodilator, consider CPAP or non-invasive ventilation, and then if symptoms are progressing rapidly, you want to consult a specialist early to know how to treat those lungs specifically. Disorder control of breathing is a fancy way of saying that the respiratory center in the brain has been damaged for some reason, and that's why the breathing is not appropriate, not any kind of an infectious process happening in the lungs. So it's an abnormal breathing pattern that produces signs of inadequate rate, effort, both. So where you're going to see that is a kid that's having seizures, febrile seizures, epileptic type seizures, seizures following trauma, increased intracranial pressure, again, following a trauma. Perhaps it's a patient that has a shunt that's not functioning appropriately. Any central nervous system infections, they may have seizures or breathing issues. A head injury, tumors in the brain, hydrocephalus could be a cause for disordered control of breathing, neuromuscular disease, or metabolic disorders. So signs and symptoms, a variable or an irregular respiratory rate. For example, tachypnea alternating with bradypnea. A variable respiratory effort, maybe they're not having any retractions and then suddenly they are. You have shallow breathing, that it appears they're breathing, but it's not enough to really move oxygen in and out. Or central apnea, where the respiratory system in the brain just is not working and their brain's not telling their body to breathe. So specific management for increased intracranial pressure. You want to open the airway and maintain the airway while stabilizing the C-spine. So use the jaw thrust as necessary. Verify a patent airway, that they're getting enough oxygen and adequate ventilation. If there is poor perfusion, you definitely want to do a normal saline or LR bolus. Administer pharmacotherapy that specifically manages ICP, like a hypertonic saline. And then treat agitation and pain aggressively once their airway is established and ventilation is adequate. So once they're intubated, you really need to knock out their agitation and keep their pain under control, or that's just going to increase the ICP more. And avoid hyperthermia. Again, we want to normalize that temperature. Managing respiratory distress or failure due to poisoning. And again, kids get into things nonstop. You want to support the airway and ventilations. You want to call the Poison Control Center for directions. They are excellent at letting you know the antidotes and then calling at increments to check on the patient. Be prepared to suction the airway in case they're going to vomit. Administer an antidote if there is one, and then diagnostic tests. Perhaps there's certain electrolytes that you're going to need to follow. Children may have a neuromuscular disease, for example, cerebral palsy, and where they don't have an effective cough, or they have a difficulty managing their secretions. So you may need to be clearing their airway frequently, laying them in a position where the secretions are able to drain from their mouth instead of possibly occluding their airway. Obviously, we always cover ABCs first, and we could provide non-invasive ventilation through CPAP, BiPAP, high-flow cannula to help manage those. That's the end of our slideshow, and be thinking of any questions you may have during our Q&A section. Thank you.